Welcome to the University of Toronto Joint Center for Bioethics Seminar Series. I'm Angel Petropanagos, and I'll be the moderator for today's session. Our speaker today is C. Dalrymple-Fraser, and the seminar is entitled Reconsidering Suicide, a Morbid Approach. Before I introduce today's speaker, I'd like to let you know that the seminar is being recorded. This lecture, along with other archived lectures, can be accessed through the Joint Center for Bioethics website. The format of our seminar is a presentation by our speaker, followed by a facilitated discussion period. We wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. Now, it is my pleasure to introduce today's speaker. C. Dalrymple-Fraser is a PhD candidate and Vanier Scholar in the Department of Philosophy and Joint Center for Bioethics, and a member of the Collaborative Specialization in Bioethics. Their primary research focuses on the relationship between silence and oppression in healthcare, and an emphasis on queer, trans, and disabled communities. Their further interests in curing and disabling approaches to suicidology are informed by plural experiences as an attempter of, witness to, and survivor by multiple suicides. Now it is my pleasure, C, I'll turn it over to you. Welcome.
Oh, thanks. And hi to everyone that I absolutely cannot see. Thank you for showing up either now or in the future, whenever works for you. I'm going to start sharing some slides right now, and hopefully, Angel, if I can just get a cue that they're showing up okay with the captions rolling underneath. Great. So welcome to my deliberately provocatively titled talk on Reconsidering Suicide, a Morbid Approach. I'm C. Dalrymple-Fraser. You can just call me C. It's a lot easier, and I prefer it. So a few things to kind of lead in. This is me. This is what I look like when I'm faking a smile. So as said, yeah, I'm a PhD candidate here at the University of Toronto. I'm interested broadly in alternative epistemologies of health practices, especially for and from disabled, trans, and queer folks. I like thinking about suicide, have for decades in various different forms, personally and academically. And what I'm presenting today is just a few weeks old, really, exploration into some academical approaches to thinking and reconceptualizing how we think about suicide in suicidological practices. This is, in general, a line of thought that came up through some teaching practices in courses on death and dying and conversations with students, and so I'm indebted to a lot of those of you if you're in the room here. But in large, whereas this presentation is a starting point on a larger research project, I'll be really excited to hear what you have to say in our question and answers periods where you can give the questions or the answers. I'd appreciate both. So starting off a little briefly here with some access reminders, I just want to start with some invitations because usually access is always a request, and just remind you that wherever you are in the world to prioritize your well-being. We're talking about suicide today, and while I am going to avoid any really explicit examples to any degree possible, and I can't control necessarily where our conversation will go later on, still, I can't predict what's going to be good or helpful for you. I don't have control over your lived environment and where you're attending from. It's very different than if we were in a shared physical space we could set up. So just a reminder that if you need to sit, lie down, stim, move around, eat, drink, or zone out, do that, right? Prioritize your well-being. This presentation, as our moderators have indicated, is being recorded. And so I encourage you also to engage with slowness. You can watch this recording later if now is not a good time. You can email me at another time. I know that I am a slow thinker. Question and answer periods, not always the most productive space for thinking through some really tough topics. And so I'll encourage you to reach out to me if you so want, and we can discuss at later times as well. Feel free to use that chat on YouTube to ask questions and share your thoughts. We're going to be moderating that for the question and answer period. And also feel free to use that, I believe it's being monitored, to let me know if I'm speaking too quickly or if my tech really stinks, so that our moderators can let me know on my end. English is my first language, and I'm a generally anxious person, so I can speak quickly or use idioms that are unclear, and I'd rather have a clear presentation than go through all the slides that we have together. Okay, so those are some quick access reminders for what is ultimately a talk about the relationship between suicide and death. And I'm interested in pulling apart these concepts a little bit and looking at the spaces between suicide and death. And in a bigger version of this project, more than we'll have time to present today, and one that is still unfolding, I'm also really interested in not just looking at, for example, the relationships between suicide and death, but also how these are mediated by things like disability, what the relationship is between disability and suicide, disability and death, and how disability mediates these conversations between suicide and death. And because everything is messy, I'm also interested in how suicide mediates disability and death and suicide and disability, and all the messy spaces in between and all this messy spaces outside of all of this. So if we're going to start, it seems pretty weird, probably, to have a conversation about separating death out from suicide, because quite clearly, when we talk about suicide, we seem also to be talking predominantly about death. And if we look at the origins of the term in English, it's actually a relatively new term. When we look at the etymology of it, we trace it back only a few hundred years. And when we do break it down, it is, of course, coming from roots of killing and oneself. And while I don't have yet the data on sort of the etymological histories in other languages, we see these patterns roughly established in other ways of talking about suicide in other languages, because it's not just an English phenomenon. And so självmord, right? Zisha, you see disown. As we go through a bunch of different languages, they break down into roughly just talking about a self-caused death or self-killing. And so it makes sense to conceptualize suicide in a way that is really preoccupied with death. But not everyone is happy with the language of suicide, even in the context of English. And so in critical suicidology over the last decade and a half in particular, several people have come up and questioned the language of suicide and what it suggests. And I know the language will not always be clear on your screen. Anytime that I'm showing text on a screen, I'm going to read it out loud, so don't worry about squinting too closely. B. Scherer, in an article called "I Am a Suicide Waiting to Happen," talks about their history in dealing with different structures of oppression, and as part of the conversation says that, and now I'm quoting, "I want to argue that suicide is a misnomer that aids a particular and harmful societal discourse of exclusion, abjection, and othering. It's privatizing, individualizing, and pathologizing death ideations, wishes, and resolves, and self-completed deaths function as defense mechanisms of structural and systemic inequalities and violence." So when we look at language of self-killing as captured by suicide, it doesn't capture the broader social context in which what we're currently calling a phenomenon of suicide occurs. Similarly, a few years earlier, in Vicki Reynolds' keynote address called "Hate Kills," that's later published in an anthology on critical suicidology, Reynolds says, "Using the language of suicide masks the heart-rending suffering, the daily indignities, and desolation that many people struggle with. The language of suicide quiets our collective discomfort and provides a cause for these stolen lives, normalizing the social context of exclusion, stigma, and hate in which these horrid deaths occur." Here, these authors and many others and many people who are non-academics, it's important to look at non-academical literature and sources of knowledge in these things in particular, have come to question the language of suicide. In this presentation, I'm going to keep up that language, largely in terms of convenience, and also because I believe that we can use words in creative context as long as we're critically aware of their social and historical contexts. And so for simplicity, I'll talk about suicide by here indicating that there has been some discomfort in general in the language of suicide in the past. And so in the past decade and a half and 2 decades, and even further back, depending where and how you look, there have been critical conversations about some of the problems in mainstream suicidology. And whenever you see ology at the end of a word, it's a critical sort of academical study here in the context of suicide, how we study and think about and practice suicide. So some common issues that come up, and I'm not going to go through all of them because that would be a presentation unto itself, is in the context of research, a real emphasis on individualism and internalism. That is, a lot of research focuses on suicide in the context of individuals, those who die by suicide, those who have suicidal ideations, who engage in suicide behaviors. It's really a local focus on individuals. And this is a problem that's regularly couched in terms of the ways that we approach medical phenomena and conversations around dying. And one of the main responses to this context is thinking about how suicide is so often better represented by a more social picture of different causal mechanisms, correlations, different pressures that lead to the context of the phenomenon of suicide, rather than locating it within individuals, within certain kinds of minds. And so related to this is a preoccupation with what people call the sciences. So psychology, psychiatry, psychotherapeutic approaches to thinking about suicide, and madness, or what we might otherwise call mental disorders in clinical contexts. Quite frequently, people's understanding of suicide is usually mapped to some understanding of mental health. This is how we often talk about suicide and about trying to intervene or respond to or even prevent deaths by suicide, is thinking about how we identify individuals who are potentially likely to engage in suicide behaviors. And a lot of the research has tended to suggest that this will be individuals who can be clinically diagnosed with certain forms of madness that we render as mental disorders. But this is based on some really observational data that many people who die by suicide do have mental disorders in their medical histories, or as can be established based on different kinds of testimonies from third parties. But we have very little ability to move in a predictive capacity from individuals who have any given mental disorder, such as depression, to the possibility that they'll engage in suicidal behaviors. The fact that many people who end up dying by suicide can be classified as having a mental disorder gives us nothing in the other direction of identifying from a broad swath of those whom have, presumably in a clinical context, something that we describe as a mental disorder. We can't predict from that group of people whom is going to engage in practices of suicide behavior or deaths by suicide. The data's not there. This is similar in other contexts, if you're clinical, familiar with different forms of clinical psychiatry, with the ideas of prodromal phases for diagnosing mental conditions, where really, while we have this correlational data of here's what happens in a present population, it doesn't give us predictive data. A bad analogy that I like to use is looking at people just buying apples in a grocery store. And I might go to a grocery store and observe that many people who buy apples that have stems on them, right? But looking at apples and looking at those which do or do not have stems, it's not likely to be predictive of which apples are more likely to be bought in that context. Again, not a perfect analogy, but if you're one of these many people who don't like thinking about numbers too much, we can see here how correlations, right, and what actually happens doesn't really give us necessary predictive abilities. And as recently as 2 years ago, on the outset of the pandemic, when the American Association of Suicidology ran some online seminars, members of the boards of directors made clear that they are coming to realize that in mainstream suicidology, there's this overestimation of the relationships between madness and suicide, and that it's something that needs to be more critically interrogated. And that's going to affect both how we think about researching and identifying suicides, but also how we engage in responding to the context of suicide. Further critiques is in the context of all this kind of literature, the majority of it is based in quantitative methods. So some meta-analyses conducted in the early 2010s and 2000s looking at those main journals that conduct research on suicide found that over 97% of the published literature focused on quantitative methods, that is, methods that dealt with numbers. And numbers are always going to be subject to different forms of interpretation. And one of the key things that we're interested in the context of suicide is why and how it happens. And numbers alone don't give us the easiest way of interpreting these whys and hows, or getting at individual experiences. And so other critiques of mainstream suicidology have called for different kinds of epistemologies, different kinds of ways of knowing what we might gain from looking more closely in routes like poetry, for example, rather than focusing on sort of demographic indicators and quantitative data. And that's on the research side of things, and these things all correlate with different practices and thinking about and acting around suicide. And so one issue in the practices around suicide is just how we define the very thing. There are many debates about how we come up with a good operating definition of suicide such that we can identify suicides when they do occur. One of the main problems with this is this tendency for individualization and internalism, where suicides are understood broadly to be something like an intentional self-caused death, or intentionally engaging in certain behaviors that one knows and desires to end in something like a death. And so we really rely on something like intentions, behaviors or actions and outcomes. But then people complicate this by looking at narratives of war or smoking and other borderline cases, and it finds that it's pretty hard to come up with a definition that captures what we want it to. But beyond capturing what we want it to, it's actually something that we can act on. And so a further issue is how to actually determine when suicides occur. When there is a death, how do we identify whether or not that death is something that we would choose to classify as a suicide in the context of medicine? And this is important because a lot of our data around suicide is based on things like death certificates and the legal ways that we categorize deaths. And so how does this happen in practice? Well, most often there are either, in very few cases, explicit indicators, either due to the physical nature of the kinds of harm sustained or things like letters left behind. But often, in many cases, we just can't tell based on appearances or based on sort of the data in the local environment. And so what is done is what's sometimes called a psychological autopsy, where we are trying to determine what an individual's intent might have been, what their histories might have been. And here, a lot of this relies on things like medical records and looking for traces and histories of mental disorders being diagnosed. Whereas we know that mental disorders aren't actually very good predictors of suicidal behavior, ideation, or action and outcome. And so that itself is a concern for bias. But we often also lean on the testimony of uninvolved parties, of family members, of friends or others to try to get a picture of someone's life. And so there's lots of concerns in general about the kinds of data that we've collected around suicide, that we generally acknowledge that there's an underrepresentation of suicide in any data that we get, that there's concerns about how we determine suicides and what we actually mean by suicides and the different ways that we analyze this. And quite simply, where suicides, the determination of suicides depend pretty critically on conducting certain forms of autopsy, we've seen in many high-income countries a general decline in autopsy rates. And so one critique of the general metric of, look, we see declining suicide rates across certain kinds of populations, is that this tends to be correlated pretty nicely with the number of autopsies being performed. If you want to raise the metrics of suicide rates, deaths by suicides in a given population, easy way to do this is just to conduct more autopsies. We can report what we can measure, and if we don't measure, it's harder to get that data. So these are just some of the issues with mainstream suicidology. And if we take these seriously, even though I'm just kind of reading it like a laundry list, this might get us to the point where we're thinking that, wow, we know actually very, very little about suicide. In practice, we find that because we don't have a lot of causal data, that we have many spurious correlational data, that it's not actually clear that many of our prevention strategies are actually effective. There's a lot of issues about how we look at data around certain kinds of interventions to conclude whether or not they are quote unquote successful in things like preventing suicide deaths. But I'm leaving this behind. This is just some critical backdrop for thinking that really we need some broader reform in how we think and talk about suicide. And part of what I want to do today is just add to that conversation and how we do that. But before that, it's probably worth just having a brief conversation about why there's so many images of mushrooms in a presentation about suicide. And that's because when I like to think about structural issues versus individual issues, I think mushrooms are really, really good, helpful ways of thinking here. I think that in many ways, the classical approaches to thinking about suicide is something like mushroom picking, that we go around identifying mushrooms in bloom, that we look for the broader environments in which they seem to be fruiting, that we look for the different kinds of mushrooms and where they're located and when they occur and how that occurs in the context of rain. But for a long, long time, mushrooms by themselves were the key focus, to the point that fairy rings, as they were so called, became a really, and maintain still today in many cultures, a really mystical element. That wandering through forests and elsewhere, we find these rings of mushrooms popping up that receive various explanations over time. Things like, well, these were where fairies were dancing around or otherwise. And what it came to be recognized is that mushrooms are merely fruiting bodies. They are just a tip of a broader network of what we call a mycelium, that beneath the surface of the soil, there are rich, interwoven, vastly connected networks that interact with all sorts of other flora within a local environment. And what happens is that in certain conditions, these mycelium pop up. They occur as mushrooms that we see, the visible fruiting bodies. And so if we're focused on this mushroom picking approach of identifying mushrooms where they pop up, trying to wonder how they come to occur, and looking at environmental circumstances, the relationships between different kinds of mushrooms, we're missing a lot more of a deeper possible analysis. And so where many Black critical feminists have reminded us that the term radical means in its etymology to grasp at the root, what I want to do in a radical contribution to thinking about suicide is get a little more into this mess, this mushy, mycelium-y sort of mess of what's possibly happening when we think about suicide. And so this is not supposed to be a drastic contribution by any ends, but I'm looking at thinking about one way that we might separate out suicide from thinking about death. And so many other people have taken different approaches, especially as I've indicated in the last 2 decades, under what has come to be called critical suicidology or critical suicide studies. And I've got on the screen, so that you can watch in the recording later or otherwise, a few recent publications that have done really well in this area to bring different attention to the kinds of ways that we ought to think about and rethink and question our conceptualization of suicide, predominantly in English literature. And from the website of the Critical Suicidology Network, and a reminder, I'll read this for you, don't worry. They say as part of their description that many within suicide research have become frustrated by the limitations of dominant, pathologizing, and medicalized approaches to suicide research and prevention practices. These people believe that suicidology is in need of a critical rethinking of its subject matter and a broadening of its disciplinary basis. They look at cultural practices of making sense of suicide, the different meanings that suicide could have, taking into account how suicide is shaped by history, politics, gender, identity, culture, media, and power. And what I'd like to do, if I can float myself up a little bit, is pretend to fall under this practice of a critical suicidological approach to thinking about suicide. So one way of maybe doing this is thinking about the ongoing present pandemic. At the onset of the pandemic, many people were concerned that suicide rates were likely to increase. And there are some pretty good reasons for thinking so. We have some relevant experiences of recognizing that things like social isolation are perhaps likely to increase certain kinds of feelings that lead to possible ideation, action, and outcome with regard to suicide. Now, this is not a linear picture. We don't have a good linear path between thinking about suicide, desiring suicide, acting towards suicide, or dying by suicide. Many accidental things come into play, such as just proximity to a hospital. But one estimation was just that the nature of the pandemic of many people who are not used to a chronic ill, disabled life of being more often inside and barred from social places, of having limited access to different kinds of social networks, of having a radical disruption of the kinds of lives that we have, many people thought that this would lead to an increase, whether presently or in a longer term future. We know that, for example, in the past, catastrophes have tended to see a drop in suicide rates at the beginning and then a resurgence later on once things, quote unquote, return to normal and we see a loss of all the infrastructural support in place. But happily, many people have found, against this initial expectation, we see something like a reduction in the number of deaths by suicide during the pandemic. And so one article from last year recognizes that many of the different social reforms that were put into place to support people during the ongoing pandemic have perhaps causally, if not merely correlated, to a decrease in the number of deaths by suicide. And for this presentation, I want to take this data for granted, right? I want to suggest that it's true, rather than having concerns about, well, how much of a population is being identified as dying by suicide as opposed to dying as a result of COVID or as what has been classified as opioid overdoses. We recognize that while there has been a decrease in deaths that have been categorized as by suicide, there have been increases in other forms of death that are hard to suss out. So here, let's just take this data for granted, right? And we see this data replicated roughly elsewhere. Another kind of broader analysis of suicide trends across 21 countries identified that there seemed on average to be either no net change in the rates of deaths by suicide or a decline in the number of people dying by suicide. One worry with this data, even though I want to take it for granted and trust it, is what countries are we looking at, for example? We know that on a global scale, while suicide is a massive endemic issue where people are expected to die by suicide on average 1 of 40 seconds within a given population, that we know that death by suicide occurs disproportionately higher in countries that are classified as lower income. And this study focused largely on middle and upper income class countries. And so what we find is different trends. For example, a publication from just last month identified that in Nepal, rates of suicide seem to increase during the ongoing pandemic. And I don't think any of this data is incompatible. To be clear, when we're in different social, legal, environmental contexts, when there have been so many different responses to the ongoing pandemic, when the ability for support varies a lot based on things like jurisdiction, it is not surprising, I don't think, for us to recognize that in many places, suicide rates have declined, while in others they may have increased. I don't think that one really pushes against the other, but I raise this as a caution of resisting this globalizing trend of taking research from higher income countries and taking that to be indicative of suicide data and rates on a global scale. Another issue with classic suicidological research, that while the largest proportion of deaths by suicide occur in lower income countries, the majority of the research is on those very American and European English speaking wealthy nations. But again, let's take seriously just in the context of Canada for the moment, which is where I'm situated as in terms of the nation state, that suicides have been in decline. I don't think that this necessarily entails that our suicide situation has improved. That is, an absolute reduction in suicide death rates tells us, yes, that fewer people died by suicide. Probably, let's take the data for granted. But this does not by itself entail that our suicide situation on a whole is any better. There's a tendency, and this is the tendency that I want us to press against a little bit here, to overemphasize death in the context of thinking about suicide. And again, this sounds unintuitive, but here's a very reasonable story that we could put forward. Maybe in the context of the COVID-19 pandemic, due to the different shutterings of businesses and public spaces, limited access to buildings, curfews in different places, inability to access certain routes of getting means for dying by suicide, more lethal means in particular, it might be that what the pandemic has done is restrict the access to more lethal forms of engaging in suicide behaviors. That if we don't have access to certain ways of dying, then it may be that death rates decline, but that suicidal behaviors continue nonetheless. They just do not lead to fatal outcomes. That focusing on fatality, or mortality as we sometimes call it, really misses the other possible consequences of the phenomenon of suicide. What happens when people engage, for example, in suicide behaviors that do not result in a death? What happens when we have potentially an increase in suicidality and intentions and thoughts about death by suicide, but don't necessarily see an increase in the number of deaths by suicide? If we have this more local picture of suicide as being fundamentally and merely about death, I think we miss a lot of possible nuance for thinking about how we are moving along with suicide, what it means possibly to have an improvement in our suicide situation. To be clear, I'm not really sure what it would mean to have a better suicide situation, because I think it's going to be really complex. If we look even just at the nuances of things like medical assistance in dying and legislated access to forms of death and suicide that are sanctioned in particular ways, when we look at the fact that maybe some deaths should not be prevented, even if others might be, as we get into that messiness, I'm not sure what an improvement might be overall. But what I'm suggesting is whatever that might be, if it is anything more than just counting the number of people who die, then we need something like a bit of a broader focus. And so here's another example if the COVID one doesn't sit nicely. And this is thinking about means reduction. right? And so this is an image of a bridge in Toronto, for those of you who are not local to here. And this bridge was the site of a number of deaths by suicide until a prevention barrier went up, which is on your screen, all these sort of vertical lines along the way that make it at least more difficult for one to die as a result of jumping from this bridge, for example. And one of the main concerns that has come up with the possibility of restricting access to more lethal ways of attempting to die is whether or not preventing access in this one way leads people to engage in other kinds of behaviors. And so a lot of research has focused on questions like, does restricting access to a certain suicide hotspot shift the problem to another location? Do people move from the Danforth down to the Gerrard Bridge, for example, in their attempts? Does putting up barriers, perhaps in a subway system, lead to people moving to another location or accessing different means? A lot of the data that's been done here seems to suggest that there's probably not such a shift. A title here for one study, and the reports in the context of Toronto yield roughly the same, that people have identified that putting up restrictions to lethal means of engaging in suicidal behavior seems to reduce suicide rates more absolutely, that there's not, as we might expect to see, an increase in deaths by suicide at proximate locations, for example. And I think, again, this tells a partial picture. It tells us how many people did or did not die by suicide around a particular means or location, and whether or not those individuals moved to other locations. And in further meta-analyses, one from 2018, we have conversations, and I'll read this again, that when reduction of access to a highly lethal method is possible, people who do attempt suicide with less dangerous means have an increased chance of survival. If the overpopulation rate of suicide is to be substantially reduced by means restriction, the fatality rate of alternative methods should be lower than the restricted method. That is to say, we should, if we're trying to restrict access to more lethal means, such as guns is a huge issue in the United States of America in particular, that we should do so in a way that if people are deterred or moved into other methods, they should be less lethal. And the goal here again is for, and it says it right here, an increased chance of survival. But the question of suicide behaviors is not merely one between death or survival. There are a lot of other possible outcomes. And if we're restricting access to more lethal means, it may be that people are engaging in different forms of suicide behaviors that are nonetheless yielding undesirable outcomes for those individuals. One common conversation around this is around the risk of permanent life-changing disability or debility, right? That a jump from a lower bridge, for example, may not yield the same fatality rates, but may lead to other kinds of health consequences. And so in thinking about suicide, the language of suicide and how we use it, one not necessarily concern, but question I have ultimately is how we tend to be using this term in a way that equivocates suicide necessarily with fatal outcomes. And so even in more critical suicidological research, we see this kind of language being used. And I'm not citing all my sources because I want to use these as examples rather than call the authors into any question, that this is a pattern that I'm using just an example of. And so here, for example, in one piece of literature, the authors say, in light of issues around conversations like attempted suicide or committed suicide, which has pathologizing tones, and that attempting and failing and completing and succeeding are not necessarily language that we want to associate with these kinds of behaviors. They say that in this chapter, they're going to use the term non-fatal suicide behavior to refer to suicidal behavior that did not result in death, the term suicide to refer to suicidal behavior that resulted in death, and the term suicidality to refer to suicidal ideation, non-fatal, or fatal suicidal behavior. And so focusing just on this non-fatal suicidal behavior and suicide language, which I take to be representative of general patterns in a lot of literature, we can look at it in terms of maybe a breakdown in this way, as I'm proposing for now. So we have this notion of suicidal ideation or intent. Then there are certain forms of actions, which we might classify as suicide behaviors, and then there's certain kinds of outcomes. And as I've mentioned, I'll just repeat again, we don't have a good linear path between these things. We don't have a good picture of what leads from one to the other. But despite this, we want to be able to talk about these things. And so one source of language that they use is that in the context of a fatal outcome, the language suicide refers to both the action and the outcome in a way. That suicide is suicidal behavior that resulted in death. It's not merely the outcome, and it's not merely a behavior. It's the combination of the two. But we use non-fatal suicidal behavior to pick out just the action in a way. That it's the behavior that's being isolated, rather than focusing on the non-fatal outcomes. Let me say that in a slightly different way. Well, yeah, saying non-fatal suicidal behavior surely is talking about the action and appealing to the outcome. The way that this language gets used in literature is to talk about the behaviors themselves, the kinds of means and methods that people engaged in. And it's not actually focused on the outcome in the same way that suicide, which necessitates death as an outcome, is picked apart. That when we focus on anything other than death outcomes, we don't classify it as suicide. We focus on the behavior by itself. And what this means is that the non-fatal outcomes kind of fall out of a lot of our attention at many points in time. That when there is an action that leads to a death, we consider that suicide in whole. If it doesn't lead to a death, we take that as a possible starting point of conversation for looking at what the behaviors may have been, what the different methods and means were, whether an individual is likely at risk of further actions down the line, but not the other possible health outcomes. And I want to focus on health outcomes and individuals, even though this is a problem for suicidology, because this will still be an outcome that even mainstream suicidologists could take for granted. So on this lens, all I'm suggesting, and I think it's a relatively small point, but not unimportant, is that a more comprehensive picture of the phenomenon of suicide requires that we attend more to the morbid outcomes of suicide and suicidality, both in theory and in practice. And by morbid outcomes, I'm using that in the sense of morbidity as opposed to mortality, those health outcomes that are not fatal, that are not death in nature. Now, this by itself is something that I think is interesting to explore, and that's the crux of the main first move of trying to separate out suicide and death, is what can we find in the productive middle spaces when we look further at the morbid outcomes of suicidal behaviors? Or do we want to redefine suicide in a way that also accounts for these behaviors that lead to non-fatal outcomes? Do we want to separate out suicide from outcome talk in the same way that when we talk about pesticides, for example, we're talking predominantly about the means. We're not guaranteeing that pesticides will always lead to fatal outcomes for those given pests, or herbicides for those herbs. We don't say that something is not a pesticide just because it did not in all cases lead to that ideal fatal outcome. There are different ways in which we could choose to use our language. And all I'm offering here is an encouragement for us to think about the ways that we do use this language. As a possible bonus, one that I've hinted at, this applies even to mainstream suicidological approaches without a critical lens. Right. While ultimately I'm really interested in the social structures and institutions that lead to our conversations around the different kinds of outcomes and facilitate certain kinds of behaviors and relationships to means and other peoples and structures of oppression, even if we take a more baseline quantitative approach that just looks at certain kinds of death data, we could nonetheless build a more robust data set of what occurs in the context and phenomena of suicide if we incorporate more explicitly conversations about morbid outcomes. And all this could be in the simplest forms is, when we're talking about a reduction in suicide rates, right? Deaths by suicide in the Canadian context during the pandemic. It's, to be clear, many researchers have been very explicit that, this doesn't paint a full picture, in part because it may be that we see an increase in deaths by suicide further down the line, that there might be a deferral because of current conditions of hope or otherwise. But those still are focused on death as an outcome. And I'm suggesting that if we want to paint a broader, more complete picture of how severe suicide actually is, and it already is on a mere fatal, mortal outlook, that including morbidity is going to help. Now we've got a few more minutes before I'm supposed to stop talking and create more space. So let me say some things about the next steps that I want to be taking in this project. And this is, again, a very new project and one that is unfolding for me. And I'm excited to explore all the different spaces between it. And as I said, I'm really interested in this ways that disability might mediate in these kinds of conversations and all the productive spaces between these. One way in which talking about disability in the context of healthcare and health ethics in general, one complication is that disability gets used in various different ways. Publicly, we often use it to refer to a social identity group of disabled people when we talk about disability justice and disability rights. But in clinical practice, often disability is used as a synonym for morbidity. That is, disability is used as language to pick out any non-fatal outcomes in the context of any health intervention or issue. And so disability is taken to be, opposed to, but related to death in these particular ways. And you can see this, for example, in language around disability-adjusted life years. And in other work, I've argued that maybe we need to be a little more careful with this language and how we pull it apart. In other ways, it's perfectly fine in that in many cases, when we're thinking about healthcare decisions, in the same way that many healthcare focuses want to eliminate morbidities, many practices seem to also want to eliminate disability. But let's put that aside. That's a whole nother conversation. Just to say that the picture of disability is going to be a little complicated. And so when we're exploring stuff like a morbid outcome in the context of suicide, I think an important question to ask would be something like this. How do we explore the broader non-fatal consequences of the phenomenon of suicide in ways that don't fundamentally rely on or perpetuate disabled beliefs of the intrinsic badness of disability? That is, it would be very easy, and people often already do this, to say things like, but what if your suicide attempt does not result in a death? What if you are permanently disabled for the remainder of your life? Wouldn't that be so undesirable? And this is used as a fear tactic, not creating new fears, but preying on ableist assumptions that are prominent already in society. And so an important question for us to ask is, how do we have this conversation? What words and language do we use that better, represents our intentions and doesn't betray disabled people more broadly? This, I think, is an important question. It's one that I encourage us to think about when we use the language of disability in any healthcare context. But I'm interested in possibly answering this question with another question, which is what even enables us to ask this question in the first place? What picture of disability is represented here when we want to talk about the non-intrinsic badness of disability in a way that often treats disability as either a neutral way of being in the world or even a positive way? And to be clear, if I didn't self-identify earlier, I'm someone who identifies as disabled, and I'm not taking this as an outsider perspective. I'm genuinely curious in what it means to ask this question in a productive way. And one reason for that is perhaps disability is not always good. Now, that's a step down the road from the conversations I usually like to have in a healthcare ethics context, because getting to this first question by itself is already a very difficult move for many people. And adding further nuances it requires us to do a lot of rethinking. But I'm interested in doing that rethinking. And so some paths forward that I think are really interesting is thinking about the different ways that we want to even think about disability, death, debility, the different ways that death might be prolonged or slowed out, that it's not seen as an instance or a state, that it's seen as a fundamental part of life as opposed to in opposition with life. And I can't possibly spell out a good decade of biopolitical literature and Foucauldian discourse and all that in the remaining few minutes, but let me try to give us some pointers here anyway. Achille Mbembe in Necropolitics, a book referred to me by a good friend, Shar, builds on Foucault's kind of biopower and biopolitics, where Foucault's talking about how we have control over life by talking about how in the current sort of political climate in many places around the world, what we've seen is actually an inversion between our values of life and death and how we assert control over them. What he calls necropolitical power proceeds by a sort of inversion between life and death, as if life was merely death's medium. Later and elsewhere in the book says his concern in talking about sovereigns is that he's really interested in the generalized instrumentalization of human existence and the material destruction of human bodies and populations. And if you're, trying to process this language, that's another reason we can't do this whole discourse in the remaining few minutes. But in short, what Mbembe wants to say here in part is that a current approach to thinking about life and death is one which legislates over death, is a question not of who do we allow to live, but who do we make live and who do we allow to die? And a simple foothold into this kind of thinking might be thinking about medical assistance in dying and the ways that we regulate access to death for certain kinds of individuals, who we make live by not meeting certain qualifying criteria for access to medical assistance in their search for death, because perhaps their clinical criteria don't meet our current thresholds, even though their lives are complicated in many different ways. Building on this, Jasbir Puar in The Right to Maim, which is an amazing and very difficult text, pulls into further tension this idea of a dichotomization between life and death, and says that we need to look also at different practices of what she calls, for example, debilitation and maiming, and that focusing on these different ways of being in the world and the infrastructures and sources of power that create the ways that we live might alter the relationships that we have to living and dying. That maiming is something that is not living nor dying, nor sort of a middle between them, that moderates that. And the example that I think is easier to pick up on is the context of Palestine, which he writes about in a later chapter, where in the context of Palestine, Israeli forces have a deliberate policy not to shoot to kill. Rather, they have a shoot to maim policy. And so when we look at death statistics in the context of Palestine and see that they're relatively lower than the political outrage over the context of Palestine might seem to suggest, it's because we're putting a particular value on death. And if we look at slower forms of death, different maiming and debilitating approaches to life, if we think about slow death as something like who we let die or make die, maiming, Puar says, masquerades as letting live when in fact it's will not let die. That is, there's this very pro-life kind of attitude when we talk about a choice to shoot, to maim and debilitate populations as a more humane approach, as one that's not as bad as killing, but nonetheless debilitates and disables people while also leading to a lot of other infrastructural issues in terms of lack of access to healthcare and other human rights violations, that many cases, the kinds of policies we enact are will not let die. What happens when we have a suicide prevention strategy that values life at all costs without having conversations about the morbid kinds of outcomes? What happens when in a broader global conversation around disability, we're focusing on disability rights and justice in a way that's really white and privilege in a lot of forms of who gets to identify as disabled and what does it mean to be disabled within a broader population in a way that is seen as either value neutral or positive? It relies on the infrastructure in place to be rehabilitated and positioned in society in a way that is very different from the situation of people who are deliberately maimed and disabled in the context of Palestine, for whom many testimonies say that death is preferable to their way of living. And so what this does is just complicate our picture of disability, right, in ways that really raise us questions about how we talk about disability in the context of suicide and death. And if this is too much for you, it's too much for me. I'm still working on it myself. But the general picture overall is that if we do have a concern for things like disability justice and all these pushes that I'm hoping we can take towards separating suicide and death apart, well, in conceptualizing suicide with this disability justice approach, we need to attend to the very multiple ways in which disability functions, such as, and quoting from Puar, right, an exceptional accident or circumstance, the way that disability is often figured in places like North America in human rights and disability rights campaigns, as opposed to intrinsic to the function of colonial war machines in other parts of the world. And by other parts of the world, I also mean the parts of the world geopolitically right here that we don't always occupy in the same way. That when we start these kinds of seminars with a land acknowledgement, that's not merely a conversation about place, but also the different social and historical relationships to place, the different peoples that occupy different places. That when we think about disability and suicide, even the context of Toronto, where I am, right, when we think about it in the context of a dish with one spoon attitude of shared resources and respect for others, that ultimately this is not what's happening in the colonial context of the nation state of Canada. That when what we call Canada currently has some of the, if not the highest rates of death by suicide in the world among some of the bands of Indigenous populations, in particular in the North, right, among the Innu and Innu peoples, What does it mean to think about disability? What does it mean to think about suicide prevention in a way that focuses on individuals rather than the fact that it costs $20 to get a liter of orange juice, right? Rather than the fact of the colonial legacy of residential school systems and the impact of trauma and the relationship between that and suicide, as opposed to, as Christian Rowland says in Dying to Please You, which is an Indigenous look at critical suicidology in the context of Canada, rather than thinking that, oh, maybe just a certain group of Indigenous people are suddenly having different hormonal imbalances that are leading to increases in depression rates that are leading to suicide. That very biomechanical focus is completely inappropriate. And so what we need to do in the context of a critical suicidological look, trying to pull a lot of threads together here, is one, we need this more critical attitude in general that looks at social relations and relations of power. Two, my hope is that we start to look at suicide and think about the ways that suicide often gets conflated with or talked about merely in terms of deaths that result from suicide, and what broader picture we might need if we're going to have a more robust research practice, if we're going to think creatively about the different ways that we respond to and engage with suicide as it appears in the world around us. And that's my talk for now.
Thanks so much, Steve. That was really great. I was like, I'm excited for this talk. And which
Are we
is
still excited?
interesting given the type. I am still excited. I mean, like going through it, it was great. It gave me lots to think about, and I really appreciate the disclaimer at the beginning around sort of the challenges around sort of the topic and thinking through it. I appreciate the opportunity to pause and think more carefully and critically about sort of the notions of suicide and death in relationship with disability. So we are going to look over to our audience now on YouTube, and Carrie will add any comments and questions that they have into our chat. So just a reminder to those watching, you can type your questions or comments directly into the YouTube chat. There's also an option to send an email if you'd like to make those comments or questions anonymous. You can send an email to jcb.ea@utoronto.ca, and we can ask those questions to see as well. So while we're waiting for some questions, I thought maybe I could give you the opportunity to say a little bit more about the conception of disability that you're imagining for the path forward. So I know you touched on it towards the end of your presentation, and I'm excited to hear your thoughts on some of the sort of what that conception might look like, or some of the sort of parameters or requirements or considerations for the development of such a conception.
Great question. Big question. Easy.
Big question.
Not at all. So first, let me just say administratively, reminder that I encourage slow thinking. So if people are thinking about, I know I have a question, but I don't know how, this recording will go live. You'll be able to see my email address. We can get in contact in other ways. But yeah, in the context of disability, so there's a lot of presentations I tend to do in the context of bioethics tend to just be around how we conceptualize disability. And one of the baseline approaches in the context of our health institutions is getting people to recognize that disability is not necessarily fundamentally bad, and what it means to take like a critical access avenue to thinking about disability. What the pandemic would look like if we had actually committed to accessibility and had wide enough sidewalks that people don't have to walk on the streets, if you could open doors with ease, if we had the infrastructure already in place for people to be able to work and live from home in ways that facilitate disabled existences in the world. I think these are important first steps. What I'm hoping to do in my further sort of unpacking of this research is lean into work by Shelley Tremaine and many other people who are focusing on the different power dynamics that come into how we conceptualize disability, that the prominent models that have been there in the past of disability supervening on some impairment in the body isn't an adequate picture. They're thinking about disability just in terms of social access to places, right? The social model of disability, where my disability is in part constructed by the fact that sometimes I can't go upstairs with ease, right? And had that not been a barrier to me, I would not be disabled in the same way. To thinking broader about structures of power. What that looks like, ultimately, I can't yet say, in part because I'm still in learning about that kind of particular avenue in thinking and conceptualizing disability. But I take it in two quick moves. First, that we need to think about disability as not fundamentally necessarily bad. And then second, once we're in that place, to recognize that disability is not fundamentally good either, or not fundamentally neutral in different places in the world. That much of how we've theorized and actively pushed for recognition and appreciation of disability has been disproportionately led by white activists, has been facilitated by very human rights centered liberal notions that have been developed in like Euro-American colonial contexts and understanding individuals as individuals and individual human rights as opposed to all my relations sorts of views and relational identity that are represented in other cultures. Basically just making disability messy in the same ways that I want to make suicide and death messy and get into just the grit of it all, dig into the dirt a bit.
Great, thanks, Steve. So we have a question they ask, when thinking about questions such as who we let die, who gets to live, etc., what would make, for instance, policies such as MAID more important than people's attitudes?
Yeah, good question. In terms of policy thinking, and with MAID in particular, I'm going to answer this by asking another question that I have in general. So a lot of the times when we think about things like medical assistance in dying, many of the conversations are how we expand access to medical assistance in dying. And a lot of these conversations in the context of where I am now in Canada in the past few years in particular has focused on disagreements within disabled communities about whether or not this kind of access is a good thing. And of course, there's going to be disagreement because we are many and diverse peoples, right? But another question that I think is interesting to ask also is about how we focus on possibly expanding who provides medical assistance in dying, or just assistance in dying in these ways. That our moves to decriminalize assistance in suicides, for example, have happened particularly within the clinical expertise and professionalization of healthcare, which is not an industry or institution that many people have equitable access to, that not many people have been serviced appropriately by in the past, that has a very specific kind of lineage and approach to thinking about different ways of existing and living in the world. So when it comes to policy approaches, in the context of MAID, I think that in the medical institutions, the moves to think about who should have access and what barriers we erect or not are very important. I'm also aware that in many communities where people who live with suicide discuss different approaches to suicide, that in many countries or places where people are not eligible for medical assistance in dying, it's where people are asking about other more lethal ways to perhaps die by suicide and concerned about public restrictions to these means as preventing them from further having this kind of access. And so who we let live or die is in part facilitated by our choices of restricting access to more lethal means. And it's part of a conversation that I think we should be having more of. I don't want to have an answer to these questions so much as be part of a broader conversation, because I'm coming at it from a very particular social position. And I think it's important to have a broader conversation there. But when it comes to things like policies and thinking about the medical sort of assistance in dying and suicide, a conversation I think would be interesting to have more of is expanding the kinds of people that we think should be exempted from these kinds of criminal provisions and interpretations of assistance. What do it mean to have non-medical practitioners who, by whatever training or policies we need to enact to make sure that there's safer access, we could have more culturally appropriate avenues and spiritual leaders and community leaders that provide more culturally appropriate and sensitive approaches to thinking about the relationships between life and death. So I don't have a good, perfect picture of policy. My ideal is we have a lot more nuanced conversation with a variety of different stakeholders to explore that. But I'd added to it the other question of how are we locating it within medical institutions, and what does that mean for how we conceptualize suicide when suicide is sanctioned in one very particular context so far, in the context of North America anyway.
So I know we're coming close to 5 o'clock to our end time, but I'm going to take the liberty of sneaking in one more question. Hopefully it's a quick one. In thinking about sort of the comprehensive picture that you painted, where there's thinking differently about the concept of suicide itself, where there's a distinction between suicidal ideation or intent, the action and the outcome, whatever kind of outcome it resulted in. So the question is whether you have any data that speaks to sort of the ratio relationship between those things currently existing, and what your wish list would be for some top studies in terms of qualitative or quantitative data that you would like to see.
Awesome question. I have a lot of mistrust of presently existing suicide data for a lot of methodological reasons that I hinted at some earlier that are common in critical suicidological critiques. But there's a lot of ways in which reading the sort of data tells us a very, I think, surface picture a lot of the time. And this is not to denigrate the people doing that research. The data that we are getting is helpful. It tells us something. I'm interested in getting those further things into the picture as well. So I want to make first that clear that I'm not poo-pooing any kind of research in particular. But I am interested in seeing more qualitative research that comes from the people with lived experiences of suicide. But I'm also interested in doing secondary approaches to research that look into the pre-existing literature out there. So much really interesting critical approaches to thinking about suicide come out of queer poetry and disabled poetry. People in communities that have been living and dealing with suicide in ways that are not academically represented for decades and decades and don't have the same kind of academic access to publishing avenues that we typically look at for collecting this kind of information. But at a very superficial level, if we did more autopsies, we'd collect more data with regard to the kinds of things in mind here. And if we attend to building up more data about what the consequences of suicidal behaviors are and doing sort of more meta-analysis by people who know a lot more about how to conduct those kinds of quantitative and also qualitative research than do I, that would be really exciting progress forward. But I'm also very particularly interested in this kind of secondary look of what knowledges already exist out there that aren't being represented in the very gate-kept academical thinking about suicide and suicide research. Yeah.
Excellent, thanks, C. So unfortunately, it's time to draw today's seminar to a close. And before we do, I just have a couple announcements to make. So our seminar will take a small hiatus with the University Reading Week break. But don't worry, our seminar will resume on Wednesday, March 2nd, and Haroon Youssef, Andrea Frolick, William Harper, and Simon Oskowski will be discussing lessons learned from educating clinicians on pandemic critical care triage protocols. In order to sign up to receive our weekly seminar reminders via email, please send an email to jcb.info@utoronto.ca. For the CSB students enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And last but certainly not least, C, on behalf of all of us here today, thank you very much for your excellent and thoughtful presentation.
And thanks to, I can't see any of you, but thank you for everyone else who turned out to be having this conversation in one way or another. It's new to me, and I'd appreciate any further thoughts that you want to share as well. Take care.